My name is Dr. Matthew Regulski. I'm the Medical Director of the Wound Care Center of Ocean County in Toms River, New Jersey. I'm also the Co-Director of the Community Medical Wound Care Center in Hyperbarics in Toms River, New Jersey, and the Director of the Kimball Medical Center Wound Care Center in Lakewood, New Jersey. So thank you very much for coming. I just want to take a moment to thank the organizers for the committee for having me here. This is a great honor for me to be here. I've been coming to this meeting for several years, and I'm very humbled to be giving a lecture in the company of such visionaries as Dr. Armstrong and Dr. Mills. So thank you very much for having me. So we're going to discuss about Regranex, an oldie but a good product that I'm sure you're aware of. There's a lot of questions and comments concerning its science and its efficacy. So hopefully we can dispel some of those things for you today. We're going to discuss a lot of the different evidence and the science behind it, clinical trial data, and the like. So I must disclose that I am a paid speaker for Smith & Nephew. I use this product because it works, because of the clinical science behind it, and the randomized controlled clinical trial data as well. Now, important safety information is you're aware that it does have a box warning, but please remember that 15 or 17 of the top 20 prescribed drugs in this country also have a box warning. So I must read this for you. Warning: increased rate of mortality secondary to malignancy. An increased rate of mortality secondary to malignancy was observed in patients treated with 3 or more tubes of Regranex gel in a post-marketing retrospective cohort study. Regranex gel should only be used when the betterments can be expected to outweigh the risks. Regranex gel should be used with caution in patients with known malignancy. It's indicated for the treatment of lower extremity diabetic neuropathic ulcerations that extend into the subQ or beyond and have an adequate blood supply. It's indicated as an adjunct, but not a substitute for, good ulcer care practices, including sharp debridement, pressure offloading, and infection control. The limitations of its use have not been established in pressure ulcerations, venous stasis, and not have been evaluated for the treatment of diabetic neuropathic that extend through the dermis and into the subcutaneous tissue. The effects of it on these exposed joints, tendons, ligaments, and bone have not been established, and it is a non-sterile, low bioburden, preserved product, therefore should not be in wounds that close by primary intention. Contraindicated in any patients with known neoplasm at the site of its application. So the objectives of the study, as you can see, are here, and many that we will try to cover. At the end, I will be more than happy to answer any questions that anybody may have regarding the science behind its data and those. So the impact of the diabetes, I know I'm preaching to the choir here, that we deal with this every day in our practices. I treat over 4,000 diabetic ulcers a year, and it's amazing how the incidence just keeps going on these patients. We know there's 70 to 80 million pre-diabetics in this country, and then we look at right now that we have upwards of 8% of our U.S. population has diabetes, and by that year, 2034, 44% of the patients in our population are going to have diabetes. Close to 400 million people worldwide will have diabetes also. And the risk of the diabetic foot ulcerations are many, and they are growing. 15% of all diabetics are going to develop a foot ulcer in their lifetime. 84% of all lower extremity non-traumatic amputations, as you know, are preceded by a foot ulceration. So the number one reason why diabetics are admitted to the hospital is for an infected diabetic foot ulceration. And that number is only going to keep going. We know that the mortality rate, as you're all aware of, that's been published by Dr. Armstrong before, showing the increased risk of diabetic neuropathic ischemic ulceration has a greater risk factor for mortality than most cancers do. So when we go back to our offices on Monday in our clinics, half of our patients have a diabetic foot ulceration, could be deceased in the very near future. The high cost of diabetic foot ulcerations is staggering, and it's just going to keep climbing. 178 billion total expenses and just in 2007 for diabetes and its related complications. We can see $18 billion treatment for diabetic foot ulceration now. We can see the annual incidence of this is skyrocketing up to 3 times higher, $15,000 just to treat this diabetic neuropathic ulceration. We can see that there's more patients that are going to go to the ER. We know that more patients are going to be admitted. More patients are going to the OR. More patients are going to have amputations, and more patients are going to have to go to rehab facilities and be fitted with $40,000 prostheses if we don't do something to help stem that tide and for us to help resolve this pandemic of a problem in our society. We know that it's the most feared complication is when we have to remove a part of a limb. I think that we despise having to cut off parts of people's limbs. We try to salvage, and I know that there's some patients, and I try to heal everybody, but I know there's some patients that we may have a very difficult time to do that. Some patients may end up with amputation, and we know the relative risk of the morbidity, the mortality, and the cost to the system to treat that problem, and the cost to these patients and their families, the emotional cost as well. And you can see from these figures the tremendous burden that diabetes does put on our society, and the costs are just going to keep rising because we have such an increased incidence for this. Diabetes affects the quality of life, as you can see from the schematic. These patients are afraid, they have emotional distress, they get depressed, they have anxiety, they start to get depressed, they activate their hypothalamic pituitary adrenal axis, and upping their cortisol, that affects their healing rates. So we can see that they feel like they're a pariah, and they're frightened, and they're afraid. My own father was a diabetic that developed a severe foot ulceration. And I can't tell you how many times when I used to speak to him on the phone about it, he'd have tears in his eyes thinking about that, thinking about, is he going to die? Is he going to have his leg amputated? So it is a very scary business that we're in for these patients. That's why we work so hard to try to resolve these matters. And of course, I think the sixth phase of wound healing should be prevention. I think in a lot of cases we can get most of these wounds to heal, but the question is, how do we prevent them from recurring? These patients have severe biomechanical deformities. Maybe compliance has an issue with it. They have severe vascular disease. They're on 1 million medications. They may be on dialysis as well. They may rely on public transportation. They can't get back to see you as often as you would like to keep good surveillance of these patients. So we have to be able to do these things to prevent the recurrence of these ulcerations, which make the cost go up exponentially. So the summary of our impact of our diabetic foot ulcerations, again, is the increased financial burden for these patients, the cost of of diabetes and its related complications, the cost for the amputations, the quality of life is tremendously reduced, and the mortality rate goes up with amputation, all of which we are trying to prevent each day in our clinics. Assessing the diabetic foot ulceration, I'm sure everybody is quite fluent in the paradigm for assessing a diabetic foot ulceration, but first and foremost is our vascular perfusion. All chronic wounds have a hypoxic gradient to them. Diabetes is a chronic inflammatory disease engendering atherosclerosis. Presence of the palpation of pulses, does it exclude the diagnosis of diabetes? So we need to have some type of a quantifying examination for these patients. Obviously, the neurological insult that occurs with these patients, the temperature, the vibratory, the plantar protective sensation, loss of deep tendon reflexes for these patients, interference in their dorsal column medial meniscus pathway through their spine, interfering with sensory signals being sent to their brain. Musculoskeletal, when they're diagnosed with a diabetes, at that time, they've lost 50% of the muscle mass in their feet. Claw toe deformity, equinus deformity, fat pad atrophy, exposing all these bony prominences to increased risk of pressure. And the dermatological concerns, possibly even fungi, xerosis, secondary to the autonomic neuropathy, creating insults to the skin and breakdown of skin barrier. So we have to foster some type of a good foundation for healing. Sharp debridement obviously is a gold standard for the debridement pathway. We know it's intuitive. We need to remove, devitalize ECM damaged cells, bacteria. Obviously, we do sharp debridement after we know the lymph perfusion is adequate, that they do have an adequate supply. In the interim, then we could start with some type of an enzymatic debrider for these patients. But lymph perfusion is key for these patients, as I've said, chronic inflammation being the underlying force for the engenderment of atherosclerosis. We know infection control. I have to be careful about, we have that bottle of pills there. I think that antibiotics are overprescribed in chronic wounds. Chronic wounds contain a plethora of bacteria. Superficial swab, how much credence do we lend to a superficial culture? There's not a lot of evidence for topical antibiotics as well. Systemic antibiotics only working in 20% of cases of chronic ulceration. So we do have to reduce bioburden because it damages the extracellular matrix. It's a continuum-itis for white cell migration, pumping out reactive oxygen species, breaking down the extracellular matrix, creating cellular senescence due to the oxidative stress. So we do have to control our bioburden. And offloading. People think that offloading is intuitive, but unfortunately, proper offloading in the form of total contact casting, or DH Walker, only occurs in 2% of the cases. I think with all the new exciting devices that we have, stem cells and the like, we could use several hundred pieces of that on a diabetic ulcer. But if we don't get the pressure off, I don't know how much good that is going to do and just increase the expense. So despite our good ulcer care, over half of these patients are not going to heal because of those underlying molecular aberrancies that we have discussed. And of course, the phases for wound healing, I know this slide may be redundant, but people have to understand how we progress and how we move through the healing cascade. It's quite a complex cascade. We really only know about 40% of how we heal. There's a lot of dynamic reciprocal interactions occurring between various cell types, reactive species that are occurring there, but bioactive cytokines and proteins, and of course extracellular matrix to propel this wound on through this healing paradigm and into restructured structural and functional integrity of our epidermal tissues. So as we're talking about Regranex and platelet-derived growth factor, obviously it modulates all phases of the wound healing system. It interacts and it can propel all those phases because of the complexity of what this molecule does. And of course, during the hemostasis, our platelets are going to degranulate, release PDGF, which then is chemotactic and mitogenic for our neutrophils, macrophages, fibroblasts, vascular smooth muscle cells. And then, of course, in inflammation, it can upregulate macrophage debridement of devitalized tissue. It stimulates macrophages to increase its production of various growth factors such as TGF-beta. And like TGF-beta, PDGF can stimulate macrophage debridement of tissue and fostering granulation formation. And then as we move in through the proliferative phase, there is a key feature that what PDGF can do on stabilizing new angiogenic structures. Now, I'm sure that people are aware that PDGF is not necessary for the initiation of angiogenesis, and its angiogenic effect may be weaker than basic fibroblastic growth factor or VEGF. But the fact remains that you cannot have blood flowing through that new blood vessel unless you have periocyte and smooth muscle cell recruitment to stabilize the architecture. And that's one of the most potent chemotactic and mitogenic effects that platelet-derived growth factor can do, stabilizing the newly formed vasculature so blood can start moving through it. And then also, in the proliferative phase, it can enhance insulin growth factor 1, which is a potent chemotactic mitogenic property for keratinocyte motility. It upregulates things like ECM proteins thrombospondin 1, which can delay proteolytic destruction of our tissues. It's necessary for fibroblast proliferation and fibroblast migration. It can stimulate fibroblasts to increase its production of proteoglycans, and in conjunction with integrin receptors is necessary for fibroblast adherence to our provisional matrix. Okay, and then in the remodeling phase, we know that it can upregulate MMPs to break down devitalized and older collagen so that we can propel on through this remodeling process. So it's a very multipotential molecule participating through all phases of the wound healing cascade. So when we should use it, obviously we have to be utilizing it with good ulcer care. Should we be putting on exposed bone or tendon, structures that are hanging out, hardware? I mean, you have to be able to utilize this in the context of all those good things that we have been taught to do. But right now, it is the only FDA-approved growth factor that is on the market. And there's been trials with VEGF and keratinocyte growth factor and basic fibroblastic growth factor, but they haven't been able to pass rigorous randomized control trial data, such as PDGF has. So when we need to know about these different properties of it, we discussed what the box warning was, the dosing, and its application as well. Again, it has to be used in conjunction with good ulcer care. We have to make sure that our blood flow is adequate. We have proper offloading. We've debrided away devitalized tissue. We're managing the metabolic and nutritional needs of our patients, managing the edema and the exudate. And then, obviously, then we can start to participate in that proliferative campaign to move this wound along by utilizing this most multipotential influencing of our growth factors. So this was the randomized controlled trial that we used for Regranex. As you can see, the multiple centers, 382 patients that were used. One had at least a full thickness chronic ulceration of the lower extremity. When you do a lot of randomized controlled trials, there's a very strict inclusion-exclusion criteria. It's rigorously oversighted, it's maintained, and very strict rules that are applied. So we can see from the randomized controlled trial data that we had 32% healing. And if you recall from the Dermagraft trial that their healing value was only 30%. So this was one growth factor that had significantly better than the control through the randomized controlled trial process. Faster incidence of complete closure for Regranex because of the multipotentiality of the molecule participating through all these phases of the wound healing cascade. And of course, compliance, we can see that there was increased results as early as 4 weeks. I think that the patients, there's more compliance to these patients because we can see that the treatment is working for them, it's cost effective, it's easy in its application, and it gives patients hope that we're able to apply an advanced modality to them to bring this to resolution, because obviously the longer it stays open, then the greater risk for infections and amputations and hospitalizations and death for these patients. So again, it should be always used in conjunction with good standard of care. You get questions a lot. I know myself and Dr. McGuire get questions all the time. Should we be using it in conjunction with other elements? Can we use it on exposed tendons and bones? And you have to use all those good practices that you were taught in order to get the wound to a stage that we can start applying a proliferative device within that wound. So greater incidence of healing and also faster healing, which is necessary to protect our patients and be able to save their limbs and ultimately save their life. Again, the box warning, just remember that 75% of the top 20 drugs prescribed in this country all have a boxed warning to them. And again, the reason let's delve into why the box warning was proposed is that the FDA was asked to review this retrospective epidemiological study requested by the European Medicines Agency. Now, this was after 10 years of use, after over 1 million applications of Regranex gel. And throughout it, they did not see an increased risk of incident cancer. There was a suggestive increased mortality secondary to malignancy, known malignancy, in these patients that use 3 or more tubes of Regranex gel. I personally have never used 3 or more tubes of Regranex gel on a patient. Now, the confidence interval here was so wide and so large that the question was raised whether the relative risk was elevated because simply by chance or by confounding. And this was based on just 4 deaths. The dosing regimen is pretty basic. I know you get questions all the time about how much do I apply? Do I apply to the thickness of a quarter? It's just simply length times width divided by 4, and that will give you the amount, how many grams that you're to apply. Easy, quick, safe. A spouse can apply it. A caregiver can apply it. We have wonderful home nurses in my area that are able to go out, and it's very simple, it's easy, and it's quick for them. They have 1 million patients to see. So it's a very simple dosing regimen to apply for these. There's a very flexible application schedule for it. You apply it in the morning, or you can apply it in the evening, obviously, to change the dressing. We need to foster and maintain a moist wound balance with these. And obviously, the preparation, I know people are very familiar, but I just have to reiterate the need for that. And obviously, do not go back and forth to your tip with whatever sterile Q-tip you're using when you apply it, because if you seed that tube with bacteria, it can grow like wildfire through there. PDGF is a growth factor, and bacteria, it's possible that they could utilize that within the tube also. So again, and please keep it refrigerated. If you leave it out once for a couple hours, it might not have an effect, but if that's repeated regularly, then it can. It has to be kept cold. Don't keep it in the freezer, but it just has to be kept within the refrigerated aspect. And again, the application to it, spreading it to about 1/16 of an inch over the entire ulcer area. Nice, even, thin layer. You don't have to glob it on. You don't have to extend it 3 inches out or in the peri-wound tissue, but just apply it to your ulcer bed. And then please keep it in the refrigerator. Keep it cold. And you cover. I mean, we know how we have to heal with moist wound balance. We've known that since 1958. That we need to have moist wound balance. That's why we don't leave wounds open to air. There has to be some type of fostering of a moist wound balance within that. Here we talk about covering it with a saline moistened gauze, and then whatever dressing that you put over the top, or any of your offloading devices that you're utilizing for that. And don't forget to keep it in the refrigerator. Keep it cold. And again, so it was the summary that we covered the box warning and its dosing and its application. And again, the box warning is there. I mean, several of our drugs, 17 of the top 20, have a boxed warning. It's not a black box warning, it's a box warning that is on there. And most of the most popular prescribed drugs that we have in this country also have a box warning. And I can give you an example that my daughter suffers terribly from atopic dermatitis. And when we take her to my friend is a pediatric derm, and he puts her on Protopic. And I said to him, Jim, there's a box warning with that it can induce lymphoma in patients. And he said, Matt, that was 22 times the normal dose, and it was administered into a particular population of monkeys. So you have to take these box warnings. They are there, but you have to understand where they are coming from. So let's review some simple case studies in the use of utilizing Regranex in the spectrum of good ulcer care for these patients. So you can see that this is a 60-year-old patient with uncontrolled diabetes, and I think this is the norm for the patients in my clinic. All of them have A1Cs of 10, 11. No matter how you talk to them about how hyperglycemia impairs collagen synthesis, how it impairs epithelial cell adherence to the extracellular matrix, how it makes our immune cell tired and lazy. It can't fight infection. We can't release growth factors from our inflammatory cells. Significant neuropathy, peripheral arterial disease. Major portion of diabetics, again, the chronic inflammation of the process engenders PAD. And this was, they were utilizing Sylvadene cream, vanished from the left foot. He said that it developed as an insect bite and had pain within his left foot. So when he presented, here you can see the size of the ulceration over his lateral fifth metatarsal base. He had significant vascular disease. I'm very fortunate that I worked with a group of vascular surgeons and vascular interventionalists that are very committed, very passionate people. We're able to get them right over to those, and they take care of them right away. They don't say, "We'll try to do something, and then if it doesn't work, we will do something for it." But they're a very committed people, so I'm very thankful for them. So we can see with the angiogram, and you can see that it had significant stenoses of both the popliteal and the anterior tibial arteries, diffuse narrowing plaques, chronic total obstructions for these patients. So here in the treatment paradigm, he went through an open bypass with in situ saphenous vein. Negative pressure was started as well, and a full thickness graft was applied to this patient. But then, as you can see, he came back and he had skin graft failure. Occlusion of the bypasses, we can see the neointimal hyperplasia, the chronic inflammation that recurs in these patients if they don't keep tight control of blood pressure, triglyceride, cholesterol, obviously, and their sugar. And then it was initially started with Santal to debride away the devitalized tissue and started on his hyperbaric for this arterial insufficiency. And then the wound was continually debrided, offloaded hyperbarics, and then obviously Regranex was started in this patient, and then it continued on through to produce a functional result in the form of this healed wound. And again, proper offloading, proper diabetic shoe gear has to be always made for these patients because, again, they are very high risk to reopen. Once they have a diabetic foot ulceration, they have a 50% chance of getting another one within a year. And so these were the results that you can see by October 8th. After treatment was started, it healed 12 weeks after the treatment of Regranex. Let's look at another study on this. 50-year-old patient with type 2 diabetes, peripheral neuropathy, peripheral arterial disease, had a status post left fifth toe amputation, had stenting of the iliacs, had recurrent ulcerations for 3 to 4 years, fully amputated a post-op shoe with cutout under the ulceration. It's a little better offloading, I would think. And then obviously here's the presentation of the ulceration that you can see under his first MPJ, equinus deformity, and his x-rays obviously were negative for the osteo in there. It didn't probe into his bone, but obviously the vascular studies have some questions about his flow from there. The initial exam, the treatment was started with sharp debridement, Regranex, and patient was offloaded with a post-op shoe and his crutches. And then we can see with the continued sharp debridement, the application of his Regranex, and then obviously producing the closed wound here at the end, and a continuing proper offloading. Hopefully the gentleman did get better offloading for him to continue keeping this wound healed, which again should be the sixth phase of wound healing, is maintenance of these patients and being closed. And here were his results for these. On September 10th, after just 1 week of the treatment, 5.5 weeks, we see less than 1 tube of Regranex was utilized for these patients. So I think that the compliance for these patients, it increases when they can see that their regimen is effective, the cost is effective for them, and I know that some of these patients can pay exorbitant amounts for this, depending upon what their plan says, what particular drug coverage that they have. But I think that when you can start showing patients results, when they see incremental healing for these wounds to prevent major problems and the risk of amputation, hospitalization, these patients are very frightened and very afraid that we're able to take care of this. And the 360 that Regranex has, very simple, very easy to use. I use this all the time. You write a prescription, you send it to them. They take care of any prior authorizations. They contact the patient. They make They take all those problems out of your hands because I'm just too busy to be able to sit on the phone and fill out paperwork. My girls are too busy, as I'm sure all of you are. We want to be able to have something take it out of our hands, fix this problem, and get this product to our patients so that we can start utilizing it. It's very simple. It's a prescription pad. You fill it out. You fill out the pertinent data. You give it to your girls. They send in the demographics. And then the patients will have this product. It's a very simple, easy thing to do for you. It's one step for you to do. They may call you for a question or they have my number and my email. They can just, if they have a question about it, so you don't have to be tied up doing paperwork for hours because that drives me nuts, and I'm sure all of you, it makes you very incensed that you have to take time out from your busy schedules in order to go through all this prior authorization stuff. So very simple to use, very comprehensive. They take care of the problem and take it out of your hands so that you can go on and treat your patients. So that's the use of utilizing platelet-derived growth factor. It's quite a multi-potential. It is influencing every phase of the wound healing cascade. It's something that you can use on these patients all the way through to healing. As you can see from the randomized controlled trial data, the highest level of evidence that we have, evidence-based medicine purports the virtues of utilizing Regranex. It's faster than placebo. There's a tremendous healing rate compared to even some bioengineered tissue that is out there. And of course, when we have the Regranex 360, takes all the problems out of your hands. You fill out a one-page prescription, and you go about your business. They do all the insurance verification, all the prior authorization for you. It is very, very simple. So we can heal our patients quicker, we heal our patients faster, and we give back our patients their life as well. Okay. Thank you very much. I know that was a lot of slides to throw at you. Does anybody have any questions about anything with Regranex? Anything at all? They want to discuss the science? Anything? Yes, ma'am. There's a microphone there. Sorry, just so everybody else can hear you.
Excuse me, Dr. Brault, San Antonio, Texas. I just have one question, and that is, you mentioned you needed saline impregnated gauze on top of the application. I wonder if you could use, for instance, a hydrogel.
I think it's whatever dressing that you feel as a clinician you like to use to maintain a moist wound balance. So if you can use a hydrogel, if you want to use a hydrocolloid, but something to maintain moist wound balance. That's how we heal through a moist wound balance. As long as it doesn't dry out and you have whatever alternative you have to that saline, you can use. I use several different types of things to maintain a moist wound balance on these patients. So it's up to your discretion as long as you're maintaining and fostering that attitude.
Thank you.
Sure. Any other questions? Anybody have any questions? An interesting case where they utilized it? Did they have a problem with it? A problem with prescribing anything? Okay. Thank you very much, and enjoy your conference. It's a great pleasure for me to be here. Thank you.